Good morning, good afternoon, and good evening. Welcome to the 726th day of continuous uninterrupted Zoom session of Ifph. Let us start today's program with a silent prayer for 1 minute. Thank you. Today, our guest is Dr. K.R. Sreeja, MD Psychiatry, completed BHMS from Government Homeopathy Medical College, Calicut in the year 2007. Worked as Medical Officer, National Ayush Mission, Seethalayam, Kottayam, Government of Kerala, India. Joined MD Psychiatry at National Homeopathic Research Institute in Mental Health, Kottayam, Kerala, India. Completed MD in 2021 with second rank in Kerala University of Health Sciences. And a few publications are also there. Publications, 8 publications in peer-reviewed journals in topics autism spectrum disorders, 3 papers, acute psychotic episodes, bipolar affective disorders, delusional disorders, obsessive compulsive disorders. With 14 years of experience, and the topic is mental status examination part 2. So now why this is more important in homeopathy? Because we all know that almost all diseases and all diseases will produce some sort of changes in mind and disposition. So also all medicines has got this ability to produce an alteration in the mental state of the patient. So we, especially the homeopathic physician, must be more aware of the situation. That is why we present this topic before you, mental status examination, by Dr. Sreeja Jaisanker. On behalf of Ifph, I am welcoming you, doctor. You can have the platform for next 45 minutes. It's over to you. Yes, Dr. Sreeja. You are not audible. Please unmute. You are muted.
Is it okay, doctor?
Yes, right. Good.
Okay. So last class we discussed about the part 1 mental status examination. As mental status examination is a very vast topic, we have to divide it into several sections. So that is why today we are going to deal with the second half. So in the last part we discussed about the general appearance and behavior of the patient. From that, what all symptoms we can elicit in a psychiatric patient. From that, what are conclusions we can make, or what are conditions we can think as a psychiatric conditions we can think from the general appearance and behavior, from the speech, from the mood, affect. All these we discussed in the last session. So this session, let us continue with thought. So considering the thought of the patient, often the thought of a person is expressed through his acts and also his speech. So in front of us, a patient, not a patient, a person who is sitting, we can get the thought of that patient through his speech or the mode of communication. So all these will give the thought. So thought, whether it is increased or decreased, that we have to consider. So usually this is reflected through speech as an excessive speech in hurried and pressurized way, or loss of speech. These are the expressions in the thought. So we discussed this in the speech session also, but from that speech, how we can interpret the thought level. So that is in the thought session. So excessive speech can be there, hurried, pressurized ways that can be there, and sometimes there can be loss of speech also. So thought flow, whether there is an inhibition or slowness of thought. So inhibition or slowing of thinking, that means a train of thought is slowed down, and the number of ideas and mental images that present themselves is also decreased. And it is experienced often as difficulty in making decisions. and lack of concentration, loss of clarity of thinking, and the strange, undescribable sensation the person says that in the head. That means they think that something in their head, some trouble, which makes confusion as a physical complaint. So we often think that he is expressing some physical complaint because they will tell that in the head, or like something I'm not getting, or they will show some confused expressions. They cannot take a decision. They can't concentrate on what we are asking. All these are the expressions of inhibition or slowness, where the train of thought is slowed down. And also the apparent cognitive deficits. Cognitive means something with the higher functions. That means something memory, orientation, alertness, all these related to this term cognitive. The apparent cognitive deficits in patients with the slowing of thinking in depression lead to a mistaken diagnosis of dementia. That means often the depressive patient, a patient who has depression, have some impaired cognitive deficits because of this slowed thinking. So that will make us a mistaken idea of dementia, because they will show the same symptoms as that of dementia because of this slower thinking. And slowing of thinking seen in depression and rare manic stupors also. Last class I discussed about some catatonic features. Like that in mania also we can see this stupor. That is a catatonic feature. So in rare manic stupors also we can see the slowing of thinking, and also in depression. In them, it is expressed sometimes as an anxious preoccupation or increased distractivity. These are the expressions of this slowed thinking. They will be anxious or preoccupied. How can they do? Because they can't concentrate. Because of this, they cannot use their mind, because mental exertion will be difficult for them. And also increased distractivity. We cannot communicate in a fluent way with them. They are easily distractible. That is the loading problem. That means their thought is slowed. Then any deviation in the normal thought process. So that is a flow I discussed. Now the thought process. Thought process means how the thoughts are formed. So normally how the thought is formed, and any deviation from the normal thought process will be expressed in some other ways of speech and behavior. So these deviations are explained by the term formal thought disorders. So any deviation in the thought process as formal thought disorders. One among that is flight of ideas. From the name itself, it is understood that something in a hurried or in a speed. So patient rapidly moves from one idea to another at a pace that is difficult for the listener to keep up with. So their thoughts will be continually moving from one idea to another. So in the speech also it is expressed as they will talk about one idea, then jump from that, like what we told often in Mathematica, that one word often leads to a story. In that manner, they will jump from one topic to another. But a peculiarity is that in flight of ideas, all these ideas have a logical connection. They are not irrelevant, or they have some connections. They are talking about one idea, and something related to that they will jump into that, and from that they will jump into another. So some connections will be there with these ideas, and it is expressed through rapid pressured speech. So their speech also will be in a rapid pressurized manner. And it is often seen in mania. It is a feature of mania. And also hypomania also we can see these mild flight of ideas. Hypomania means it is same as that of mania, the symptoms. But the feature, the peculiarity is that in hypomania, the function of the patient is not altered, whereas in mania, patient is not productive. In hypomania, they can do things. Their function is not affected. So in that, mild flight of ideas can be there in hypomania also. That is known by the term prolixity. This mild flight of ideas. That is, their thought rapidly jump from one idea to another, and ultimately there are overcrowding of ideas. And another one is circumstantial thought. Another formal thought disorder is circumstantiality. Circumstantiality, the patient over-narrates the idea and unwanted details. When we are asking about something, they will describe something unwanted, but that is related to that thing, that unwanted trivial detailing will be there. And there will be connection between the content of speech. So when asking about a cow, they will talk about a coconut tree, like the grass near that. In that way, they will describe something unwanted, narrations will be there. And circumstantiality can occur in the context of learning disability and also in individuals with obsessional personality trait. In obsessional personality person, they will have also this unwanted trivial detailing of things. So ultimately, they will reach the goal. That is the way this thought process of circumstantiality going on. That is unnecessary trivial detailing occurs. Then again, they will detail the another thing in detail. And again, the trivial detailing again and again, ultimately, but they will reach to the goal. Whereas in flight of ideas, that also have some connections between the idea, but they will never reach the goal. They will jump from this idea to the connected idea to the next connected idea, but they won't reach the goal. That is the difference between flight of idea and circumstantiality. Then tangential thought, another one, another formal thought disorder. Tangential thought means at first it feels as if similar, but patient never returns to the original point or question. And tangential thoughts are often irrelevant too, and they are not connected. In flight of idea, also they won't reach the goal, but these ideas have some connection. Whereas in tangential thought, these ideas do not have any connection and they do not reach on the goal also. So we will feel it as an irrelevant talk. They keep on talking about unrelated things. And perseveration means it is a tendency to focus on a specific idea or content, because something will be there in their mind and they will fix on that and they will often talk about that. And this include often repetition of words, phrases or sounds. So often we can see in the autism patients, because they will be having some stereotypic interest. This stereotype is also have some perseveration, something. They are more interested with something and they will talk about something. Sometimes when we are asking them about their name, they will tell their name. Where is your house? Then again they will tell their name. Where are you going? Again they will tell their name. Because this is perseveration. They are sticking on to that only, not to another thing. That is perseveration. So normal thought is going in a straight pattern. They will start and will finish in a normal way. Whereas in tangentiality, they will start, but they will deviate and they will never reach, or they do not attain the goal. It will deviate somewhere else. That is tangentiality. Then loosening of association or derailment of thought. Derailment means they are moving from the normal track. So loosening of association, that means there is no association. So breaking down in the logical connection between ideas and the overall sense of goal directedness. So the words make sentences, but sentences do not make sense. They will keep on telling something, but they do not make a sentence. So usually it is seen in schizophrenia. This loosening of association is a feature of schizophrenia. These 4 A's are there in schizophrenia. Among one, that is loosening of association. Others are affect. Affect means that is, last class I discussed about the affect part of mental status examination. The present mental state, present mood state, the emotional level at the moment, that is affect. That will be affected. Then ambivalence. Ambivalence means they have a dual tendency, whether it is right or wrong, like that. That is the ambivalence. Then autistic means they will withdraw to themselves. That is autistic, not related to the disease autism. They will withdraw from the reality. That is this term autistic in schizophrenia means. And association, that is this loosening of associations. These are the 4 A's of schizophrenia. Then clang association. Clang association means thoughts are connected by sounds or words rather than by meaning. So without meaning, some sounds or some words in between that will connect the words. That is clang association. Then neologism means new words in place of conventional use of words. That also we can see in autism spectrum disorder. In them, they will make some words for some objects. That is not in the proper way. That is for an aeroplane, they will tell it is air car, or for the stomach, they will tell the food vessel. Like that, something related term will be there, but they will use it in their own convenience. And thought blocking means there is a block in the flow of ideas. So they cannot interact. While we are talking with the patient, they will be communicating, but in between, they will stop and they will not utter anything. There will be some block in their thought. Clanging means some association, that is pairing of words that have no relation. That is some nonsensical verses, like they will be similar, like cow, so, and how. So rhyme of sounds will be there, that will be connected with something rhyming words. Clang association, how are you feeling? Well, hell, it's well to hell. That is something similar. And the weather, so hot. So you know it runs on a coat. So hot, coat. All these words are used. That is a clang association. Then possession of thought. So discussed about the flow of thought, process of thought. Now is the possession. How the thoughts, this possession of thought occurs. That includes thought withdrawal, thought insertion, thought broadcasting. All these generally known by the term thought alienation. Thought alienation means some foreign power is controlling. Some foreign power is controlling their thoughts. That include thought withdrawal or thought deprivation. That means they feel that their thoughts suddenly disappeared and are withdrawn from their mind by a foreign influence. So they often say that the neighbor know what he is thinking, because they can understand what I am thinking. They are taking my thoughts from my brain. Definitely schizophrenia patients will tell this. We can see in the OP. My thoughts, they came in the neighbors. They could understand. They are discussing that. And thought insertion. That means your patient knows that thoughts are being inserted into their mind and they recognize them as being foreign and coming from outside. They think that I have such a thought. It is not because of my thought, because my neighbor is putting this thought in my thought, in my brain. They are keeping this. They recognize it as a foreign thought and it is coming from outside. And also thought broadcasting means others are thinking along with me. That is, their thoughts are broadcasted. So in newspaper, if one news comes, they think that this is my thought. They are expressed in this newspaper, or in TV. They tell that they are telecasting my thoughts in that field, or in the other world. Others can hear my thoughts. Like this, all these comes under the common term of thought alienation. So these are if any of the three are there, that can be a confirmatory symptom of schizophrenia. They are the first rank symptom of schizophrenia. There are many first rank symptoms. If these are there, any of these are there, we can think about definitely about schizophrenia. That is thought insertion. Somebody is putting inside their thought withdrawal, they are taking it outside. That is, this is thought broadcasting. They are thinking that others know their thoughts. Television broadcasting that their thoughts are communicated to the entire world. Then the content of thought. What is there in the thought? That is the content of thought. That include usually ideas, delusions, etc. Guilt, poverty, persecution. Delusions include this: guilt, poverty, persecution, nihilistic delusions, grandiose delusions, infidelity, control, hopelessness, helplessness, obsessions, phobia, suicidal, homicidal. All these thought contents we have to inquire. What are there in the these are the delusions. Thought content include delusions and also obsessions, hopelessness, phobia, suicidal thoughts, homicidal thoughts. What is there in the content that we have to elicit? So for that, we can ask the patient, how do you feel? People want to harm you. That can be considered as a delusion of persecution. Sometimes often person are suspecting others will do harm for me. They will make complaints about me. So that is a persecutory idea, a delusion of persecution. Do you have special powers? We can ask. Sometimes the patient may think that I have a special power. Lord Kali is inside me and I can do that, this, I am Jesus, like that. So that can be a delusion of grandeur. That is often seen in mania. Person thinks that he himself a great person who is having powers. That is a delusion of grandeur. Do you have strange body sensations? That is to elicit whether any somatic delusion. Some often in schizophrenia patients, we can see that they will say, there is some crawling sensation under my skin. I know that it is a chip kept by somebody inside my body. So that is a somatic delusion along with a persecutory idea. So that also we have to ask. Do you have any strange body sensations? Are there thoughts that you cannot get out of your mind? That is about the thought insertion, thought withdrawal. All these we have to elicit in that way. Do you think about the end of the world? That is often in nihilistic delusion. In nihilistic delusion means they think that they are not existing. The world is also not existing. So that is often seen in depression. That means the end of the world. Can people read your mind? That also in thought broadcasting, thought withdrawal, some alienation is there. Then anytime TV talking about these, all these questions we can use to get the content of thought. So otherwise also a person may communicate with us in the presenting complaint, maybe also showing these symptoms, or in the mental status examination, but if we are not getting it directly, we can ask these questions. Then delusions in detail. Delusions means, what is delusion? Delusions are false fixed ideas which are not shared by others and which cannot be modified. Because this is a false fixed idea. We cannot modify that. Even with evidences, we cannot change that thought. That is delusion. Common delusions are grandiose, what I have mentioned: erotomanic, jealous, love, ill health, guilt, nihilism, poverty, somatic, persecutory, etc. Grandiose means the person thinks that he himself is a great person. He may not be a great person, but he thinks. Erotomania means they think that they are in love with someone superior, or some famous person is in love with them. That is known as erotomanic delusion. Jealous means jealous, or it is a suspicion that their spouse is having a relation with some other. That is a type of delusion, delusion of jealousy or infidelity. Love, delusion of love also, that also comes under this erotomanic and jealous. Ill health, they believe that they are not healthy, they have some disease. And also guilt, they are guilty for something they have not done. That is often seen in depression. They think that this happened in this world because of me. It is not because of them, but they strongly believe that it is because of them. We can give them evidences to show that this is not because of you, but they don't believe. They think that yes, it is because of me. That is delusion of guilt. Nihilism, I told, that is they believe that they are not existing, the world is not existing, nothing is there. That is also seen in depression. Delusion of poverty, they think that they are losing their money, they are becoming poor, they are poor. They may not be poor, but they believe that I am not rich, I have nothing, nothing in my hand, nothing with me, I am poor. And somatic delusion, that is the feeling of bodily sensations. They believe that they have this and they can feel that. That is the somatic delusions. And persecutory delusion means they believe that someone is trying to attack them. They are doing harm towards them. And check whether they are congruent with the mood. So if the person is in a happy, elated mood, and if they are grandiose, that is okay, that is congruent with the mood, that can that shows that person often will show these manic features. So grandiosity is congruent with that. And a depressive feature, if a person sits with a depressed, if a person has a depressed mood and they are dull, and they say that this is because of me, this world is suffering. So that is delusion of guilt. So that is congruent with his depressed mood. So we have to check it whether these delusions are congruent with the mood. Then nihilistic delusion, I expressed, that is the patient denies the existence of their body, mind, their loved ones, and the world around them. These delusions are seen in severe agitated depression. Agitated depression means it's extreme form of depression. In this, the person have some expressions of self-hurting, destroying things. So in that, this nihilistic delusion can be seen. And also in schizophrenia, also in states of delirium, we can see these nihilistic delusions. And some nihilistic delusions are associated with the delusions of enormity. And Cotard syndrome. Cotard syndrome is also a type of nihilistic delusion, but they believe that their body parts are decaying. It is related to their body, this Cotard syndrome. They believe that their body is decaying, their blood is not flowing. They think that I have no blood in my body. It is solidified. Like that they think. and my stomach is not there. I can't eat things because my stomach is decaying. That is Cotard syndrome. Then delusion of poverty in depression. Then persecutory delusions. It can be seen in organic conditions also, because if the organic conditions involve the limbic system is the where our emotional brain is situated in the limbic system. So if any organic pathology involving the limbic system also, we can see these persecutory delusions. Then most commonest among the married people are the delusion of infidelity. That is suspicion of their spouse. In the film, in the novel Shakespeare's Othello, we can see this character is having this delusion of infidelity. He is suspicious of his wife, and he finds proofs for that. And he strongly believes that she cannot convince that she do not have that relation. Ultimately, that person kills his wife. So that is the end result of this delusion of infidelity if these couples are staying together. And delusions of infidelity in paranoid schizophrenia, but more in alcohol dependency. So delusion of infidelity is more commonly we can see in alcohol dependence. And delusion of infidelity in affective psychosis also. That means if mania and depression with the psychotic symptom, in them also this delusion of infidelity can be seen. Delusion of reference. Next one is reference. That means somebody is referring to them. That is, they are talking about this person. They feel that they are telling about me. If they are walking in a road, if two persons are talking to among themselves, he thinks that they are talking about me. That is the delusion of reference. That is also seen in depressive illnesses, because in depression they believe that they are worthless. So others are talking about me, about my life, that I am nothing. That is his belief. Then delusion of love or fantasy lover, I told, that is erotomanic delusion. They strongly believe that somebody in higher position is in love with them. It is not really, but they believe strongly. They will keep the film star's photo in their room, and they think that I know they are in love with me, but because of the social norms, they are not approaching me. They strongly believe like that. And delusions of grandiose discussed about, that is seen in mania. They think that they are a great person. Then delusion of ill health in depressive illness and also in schizophrenia. So this is the delusion of reference. That is, this picture shows that in the radio, it says that here is a song just for you. Then they think that, yeah, it's thank you. They are thinking that it is for them. And delusions of grandeur. They think that they are a great person. They are king. And delusion of reference. If two people are talking about themselves, he thinks that it is about him. This is the delusion of persecution, that everybody is trying to harm me. They will attack me. This is the nihilistic delusion, that this they are not existing, their life is not existing, and their body is decaying. That is nihilistic delusion. This is delusion of infidelity. They think that their spouse is not loyal to them. They have some relationship with others. That is delusion of infidelity. In the delusion of infidelity is very difficult to get in our clinical practice also. We cannot understand, we cannot conclude that it is delusion of infidelity. Sometimes it can be the real thing also. But in alcoholic patients, if they are telling, we can suspect that it can be a delusion. And in delusion of infidelity is then it is better to separate these partners. Otherwise, the one who is having this delusion can even kill the other one. This is the erotomanic delusion. In this, the person thinks that Marilyn Monroe is in love with him. That is erotomanic delusion. Then delusion of guilt in cases of depression, where the patient often reproaches himself. They will tell that I am, because of me, this is happening, because of me. That is, the reproaching will be there often. And delusion of guilt may often lead to delusion of persecution. So because of me, this happened. So they will take action against me. So that will turn to a delusion of persecution. So because of this delusion of guilt, this delusion of persecution can also develop. And delusion can be of desire and non-desire nature. That means desire or implausible delusion means something that could never happen. That is, their belief is there, but that belief will never happen in a real life. They think that somebody in another world will come one day and a prince will come from the other world. and he will take me from this world. They believe that and they will expect him. So that is a bizarre delusion. And they think that one day an alien will come and give me a message. That is also a bizarre delusion. That will never happen in real life. But non-bizarre mean it can happen in real life too. That they think this delusion of infidelity itself, my spouse is not loyal to me. So that can happen also. And delusion of guilt. Sometimes if they have done something, they can have the guilt also. So that are bizarre, non-bizarre delusion. So whether what the person is telling, whether it is bizarre delusion or not bizarre delusion. These are a bizarre delusion, that is imagining impossible situations, that is in bizarre delusion. Non-bizarre, that is delusion of reference, if other person are talking about them, or infidelity, that is the delusion of jealousy, that my spouse have relation, that is imagining a possible situation. And whether it is mood congruent, that also we have to check whether it occurs in a manic or depressive state. Erotomanic delusion can be there, because manic patient believes that I am a great person. So a great person can love me. So that is a mood congruent delusion. Mood incongruent also. That means in manic person, there can be a feeling that I am powerful. Along with that, this world is not existing. That means this is a mood incongruent type of delusion. Then obsession. So we talked about the main content, that is the delusion. So if delusion is there, that is a psychotic symptom. If usually the word psychotic in psychiatry means there will be a disorganized speech, disorganized behavior, delusions and hallucinations. If all these are there, we can tell that it is a psychotic state. So delusion is a psychotic symptom. If anything, any delusion present, we can think that there is something psychotic. And next one is the obsession. Obsessions are unwelcome and repetitive thoughts that intrude into the person's consciousness. And the content of obsession is often of a nature as to cause the sufferer great anxiety and even guilt. Because in this, they are trying to avoid this thought, but they cannot control that thought. They know that it is unpleasant. They know that it is unwanted, but they cannot control that. It is coming into their mind again and again. That is obsession. So it appears against the person's will. Obsessions occurs in obsessional states, depression, schizophrenia, and occasionally in organic state. If it is occurring against the person's will, that is, a person strongly believes that these germs are there in the floor. They know that it is not like that, but they have a feeling that it is there, it is there. So it makes them disturbed. So that is against their will. So that is known as ego dystonic, something against their will. That is ego dystonic. And it can be seen in obsessional state. In obsessive compulsive disorders, these obsessions can be there. There can be simple obsessions also. There may not be always the compulsion. Sometimes only thoughts. There may not be acts. That is only obsessions. And depression, we can see obsessions. Schizophrenia, there can be obsessions. And occasionally in some organic states also, there can be obsessions. This is the obsession of cleanliness. Then thought content, paranoia. So delusions discussed, obsessions discussed. Next is paranoia. Asking the patient, do you ever feel like someone is following you? We can ask like that. Asking about the patient, worrying about some cameras, microphones, or government, anything. Or so that is, sometimes persons thinks that they won't go to the toilet. They think that somebody kept camera there. I can't sit in my room because camera is there. Or somebody kept microphones there. Or government is taking some actions against me. All these are some suspicion. Paranoia means some suspicion is there. They are always in a suspicious feel. That is, they have a general feeling of suspicion. This general suspiciousness is known by the term soft paranoia. So often this paranoia, it can be normal intensity also, but it can be in increased intensity in disease conditions, in psychiatric conditions, especially in paranoid schizophrenia. In paranoid schizophrenia, the symptoms which are prominent are the paranoid symptoms, suspiciousness. They think that they are suspicious of everything. They are cautious. Then phobia, another thought content. Phobia means it is a morbid fear for certain objects, situations, or events. There can be fear, but is morbid in nature. If a morbid fear for certain objects, situations, or events, that is phobia. It can be agoraphobia, social phobia, specific phobia, or isolated phobia. That is an intensified fear. This is acrophobia, first one. That means they have fear of heights. Arachnophobia, fear of insects. Nyctophobia, fear of night or darkness. Aerophobia, they have fear to fly. Social phobia, they have fear to come in front of others. Glossophobia, that also they cannot express. Agoraphobia, that means they cannot come out. Open spaces fear, they want to sit inside. Claustrophobia means fear of narrow spaces. These are some of the phobias. There can be specific phobias also in the form of some objects or some animals or something that are specific isolated phobias. Then we have to inquire about the suicidal and homicidal ideas also in thought content. Ask about any idea, plan, and assess the risk also. Whether you have committed, whether you have attempted suicide anytime, or are you thinking that you want to end your life, or you have any plan to do a murder or like that. We have to inquire. Usually persons with personality disorders like borderline, antisocial, histrionic personality, these we have to elicit. Borderline personality disorder persons often will show suicidal threatening. They will tell others, I will commit suicide, and they will they may scratch their veins. They won't do it in, don't want to die, but in order to threaten others, they will express that they will do. And antisocial personality, often they will do murders also. And histrionic personalities also will show suicidal attempts because they want the center of attraction. So they will do dramatic behavior. As a part of that, they may take a knife and show that I will kill myself or I will kill you, like that. So homicidal ideas in paranoid persons and in severe depression. In severe depression, there will be homicidal ideas because they believe that we often hear that the person killed his family and ultimately he also committed suicide. Because in mass family suicide, one person kills others and he commits suicide, usually depression. Because of their nihilistic idea, they are doing this because they think that if I am not there, my family will suffer and they will end. So because of in order to help them from the suffering, he is killing them also. So that is the homicidal idea in depression. The mass suicides are because of that, mass family suicides. So that's all for today. Again, we have perceptual disturbance portion that we can continue as MSc part 3.
Yes, a very nice presentation. A lot of topics are discussed. In fact, this should be presented at least in half a dozen days. That much content is there. It is beyond our capacity to remember all this. That's a long problem. Excellent presentation, and it's a time for discussion. After a gap of 3 to a couple of days, our Sreeja group sir is again back in action. Yes, now could you please close the screen sharing? Okay, I shall do it, no problem. Okay, yes. Yes, sir, Sreeja group sir is ready, and please unmute, sir.
Yeah.
Yes,
it's a wonderful section. What that Dr. Manoj was telling, it was a 100-mile speed. It was a little slower, it was better, but otherwise 100 to 100 marks. That your expression, your way of approach, your subject knowledge, your voice modulation, everything was good, and your knowledge regarding to the mental these things also very good. Excellent, keep it. I like to ask one question. Whether when you are taking to the cases, whether the patient will tell all these things or not?
Sometimes, sir. May not always, but we have to elicit with our observation and our questions.
And then what about to the part of to the bystander or to the relatives or the spouse?
That also we can inquire. That comes in the psychiatric interview part, sir. In the MSc, we are concentrating on the patient only.
Okay.
It is a mental state of the patient.
Sometimes the patient may not able to tell correctly the information what I experienced, because I am treating last 25, 30 years I am treating the mental patients. That is why I asked this question. That is why I asked this question, whether they may tell or not.
They may not tell, they may tell or may not. If they are not telling, we have to make some other conclusions, and we can inquire with the bystander also, whether it is correlating with that.
Okay, thank you very much. Excellent. Keep it up. Come again with that, the other part. Okay, thank you.
It's a real challenge for the physician to understand all these things. The perplexities of case, and a lot of patients or busy, maybe busy, and also his mental status or mental state is also not good, often due to some domestic problems or personal problems, as is often the case, especially those who are counseling or doing some psychiatry studies, often become some sort of prone to develop, often saying some sort of psychological problems.
I like to ask one more question, that is whether you are practicing in Trivandrum. I have some few patients I like to refer.
Not in Trivandrum, sir. I am at Vaikom. I have patients from other districts also, sir.
Oh, okay. You know that.
Definitely, she should have patients from other districts. It is the duty of the IFPS to give propaganda like person like you and promote like you. Yes. Now, Dr. Abraham Vaidyan is there. Dr. Abraham Vaidyan, you can unmute now. Yes.
Just like the earlier classes, is also very good, very informative. I think the homeopathy doctors who are treating psychiatric cases must know the basic of like these things. These are the basic things in psychiatry. If we are not aware of these things, we can cure the patient with our medicine. But in public, we will not be appreciated because if we can associate with a psychologist, they think that we don't know anything. So these basic things to be are very essential for a homeopathy doctor. If we associate with a clinical psychologist or a psychologist, we must give direction for this and these things. If we don't know about these terms, how can we communicate to them? So we are having wonderful remedies, wonderful medicine to treat this type of ailments, but we must thorough with the vocabulary what she said. So thank you, madam. Very useful class. Thank you very much.
Yes, that was Dr. Abraham Vaidyan, is another legend from Kerala, doing a lot of work, research workers and a lot of thinking, meditations in homeopathy. Thank you, Dr. Abraham Vaidyan. Dr. Hariharan sir is there. Yes, Dr. Hariharan sir, please unmute. Yes, sir, please unmute. Yeah.
Okay, Dr. Sreeja, academically, your class is fine. But one of my suggestions is that whenever you take the class, you have to link it with the homeopathic medicine. Then only we, the poor homeopaths, have understood the exact spirit of that in the class. So one of my suggestions is that. Another thing is that I want to ask a question to you. See, is there any chance of homeopathic aggravation for mental symptoms while you are treating a mental patients?
Yes, sir. There can be.
Okay, like if a suicidal tendency patient is coming to you and you are giving the Oramed, suppose the potency is very high and the aggravation happens, what will be the result? That is
if there is a suicidal content, we have to be careful, sir. We have to assess the risk. We have to assess the intensity, the severity of the suicidal thought. Depending upon that, we have to decide whether this patient to be treated as an inpatient. Then we have to make the necessary arrangements to observe that patient also. And also we have to make the bystanders aware of this condition also. If we are sending home, We have to make the arrangements.
Okay, about that means there is a chance.
There can be, sir.
Okay, very good, very good. I asked this question to some experienced homeopathic doctors, but they said to me that there is no chance of such a condition. But I think I am completely agreeing with you, and there is a chance for that. Okay.
Yes, sir. Yes,
Very
there
correct.
is. Yes, when we
If
must
the
think.
patient
Yes.
if the patient is susceptible to that medicine, it will happen very quickly.
Sir, but yes, sir, but from the provings, the Provers Club, a lot of informations were recorded, and not a case of suicide or something were recorded. I don't know if is anything there, because we know our medicines are proved and proved and proved again and again, but none of them report such an incident. So what here our intention is to sensation as if. Just like that, not up to the pathological level. It will not prove. This is none of our business, sir. We are not at all going that level. So if what happened is that definitely our opponents will capitalize on this. Then they will say that, yes, homeopathy medicines will definitely cause this on that. So that is not at all good, sir, I think.
Okay, doctor, there is a logic. There is if the physical.
No, sir, I think there is no logic, sir. Because this is the logic, because it just creating a mild transient changes as we studied. It is sort of transient. Because who is doing this? A well-qualified physician, expected very qualified physician who is doing that. So
okay.
Yes, sir.
That I am agree. But there is a chance. But what Dr. Sreeja said is very correct. We have to observe the patient. We have to.
Yes, definitely. Observation has got its own role. I think we can come to that topic later. But Dr. Sreeja Jaisanker sir is there. He is more experienced physician on that also. Now it's Dr. Eliama George. Yes, Dr. Eliama George. Yes, doctor. You can unmute now, madam. Yes, Dr. Eliama George. Madam, please unmute. Yes. Please proceed. Yeah.
Madam, your presentation is unbelievable. That much broadcasting. But what I wanted, I got a patient. He thinks that parents are not loving him, so he's staying with the teacher and wanted to be with him. I don't know which group he is belonging. Otherwise, he is always everything is okay. He's very clever, very not nowadays not adjustable because of the thoughts. I wanted to bring him to you. Will you give me your number, phone number?
I have given it in the chat box, madam.
Please tell me. I cannot get it from chat box.
And I will put in the group.
Okay. Okay. Where you are in Trivandrum?
No, madam, Vaikyam, Kottayam district.
So can't be bring, but how to manage?
You can have a telephone call with Dr. Sreeja and she will give you enough information, madam. Yes. Anyway, for your enthusiasm and your potential to participate in discussion is welcome, doctor. Then another person, okay. Mr. Ahmad Hassan is also requested Dr. Sreeja to put your telephone number in the chat box. Yes, you can do it.
Okay, thank you.
Okay, yes. Okay, doctor. Then regarding the earlier we have said about the drug proving, the role of medicine, will it cause any problems to the patient if there is a aggravation of the symptoms? Sir, what is your opinion, sir? You are an experienced person for almost 50 years now. Yes, sir.
Yes, doctor. I experienced. I was the head of the institution in Kurichi, Kottayam. So
Yes, sir.
during the time, there are several times that the suicide had happened, but that it is not due to the medicines aggravation. Even in a suicidal tendency, mostly it may not happen because somebody will find out or it may fail. A very 10 or 15% only will succeed. The 85% may not be succeed because even they may think and they may decide. Definitely they will done without knowing anyone and it will be happened. But rest of the people we can save. That is my experience. I don't know the others, that the theory is far different from the experience. I am having now one patient. He is recently from Calicut. He is tried for suicide, but that before giving my medicine, they took to the allopathic institution and they gave some antidepressant medicine. Now he is all right, but he wants to the attraction of his wife. Always he will tell that I am going to suicide. I am going to suicide. See, it is sometimes attention seeking also it can happen. Sometimes it is not real suicide. It is my experience, but rest of the things we must have to experience and to tell, then only we can say. And even the Kurichi, that our institution, there it is psychiatrist and psychologist, everyone is there visiting and they are guiding properly. So they will guide and they will give all these details. Their training is very good. From that Dr. Sreeja's class itself, we can understand there is a very good that the training they are giving there. Actually, they are seeing so many cases also. If they are not during the time of the corona, rest of the time it was full. There was no bed, it's not available. That much I am confident about that. Okay. Thank you very much. But rest of that I cannot answer. That is my experience I am telling. Rest of that.
Yes,
that you must
okay.
have to
I
learn.
think there are enough literature in homeopathy regarding the mental diseases and where you can find out the solution for this question. Then is it, if anybody would like to participate, you can ask now. There is a suggestion from Dr. Veena. She said, palladium is an excellent medicine for delusion, neglected he is. Palladium.
For
Anybody is there?
palladium,
Palladium.
for
Delusion, neglected he is.
Yes, sir.
Yes.
It is represented in repertory also. Delusion, not appreciated.
Yes. Yes, I think these symptoms are very common in almost all persons. Who is not desire to have recognized? Who is want care of others? Almost all persons recurring at different stages of life, in different dimensions or different quantities. As age advances or age decreases, in both extremes, everybody requiring some sort of care, isn't it? Yes, now Dr. Abraham Vaidyan is there on second. Yes, Dr. Abraham Vaidyan, please. Yes, Dr. Abraham Vaidyan. Yes, yes.
Regarding palladium,
Yes.
it's a main theme is to regarding love. His delusion is he's not getting enough love what he wants to need. That's the main thing about palladium. So palladium may have these delusions. So it's maybe the best medicine also for many cases. Okay, thank you.
And Dr. Hubert De Silva was there earlier. Raise the hand. Dr. Hubert, are you there? If anybody is there to would like to participate, 3 to 4 minutes remaining, you can raise your hand or open your camera. Anyway, I think this is the most unexplored area in the homeopathy, the psychiatric disorders. As anyone in the 212 says, almost all medicines has got this ability to produce symptoms in patients or to give some relief to the patient with mental symptoms. Now, Ahmad Hassan sir is there. Yes, sir, please unmute. You can ask. Please unmute, sir. Yeah.
Good evening. to all. Madam Sreeja, very respected and very good presentation, especially for the review as well as to learn the most appropriate terminology in the psychiatry and mental status. Thank you very much. May Almighty bless you to all, especially for the organizers, because they are bringing so much consultant on the platform for the awareness as well as for the human being. Thank you very much.
Yes. Okay, thank you. Now, Sudhir sir, how you are administering medicines to patients when they are relucting to or not willing to take medicine? What is the methodology, sir? Followed, sir.
Sir, I am in the government, it is a different thing. My private thing that I am using even water, the drinking water, I will put it. And I am usually using the 50 minutes in my private practice. I will ask them to put it into the drinking water itself. So they are not knowing. Even milk also, I may ask them to put. But sometimes even the food, I don't know whether it will act or not. In a few cases, even they suspect that some patients are very suspicious about the poison. They don't even drink to the water. Even in Kurchi, one case I treated that she was not drinking water from the hospital. Even suspicious. I treated with the arsenic, suspicious to poison with that symptoms. It is better and not completely cured. It is under treatment still.
Yes,
It is, such
Yes,
cases are there. So we can do it without knowing them, that put it into the, because the 50 minutes potency medicine, very few pills may be dissolved in water and put it in the water. They may not know at all.
Okay, sir. Dr. Sreeja, what is the latest strategy there in your institution? How you administer the medicine?
We never, as Sridhar sir has told, patients are there. I have seen patients telling like that. Someone patient demanding his parent to bring a distilled water fresh for him and a sealed bottle every time. He is suspicious of even drinking water. Such patients are there, but at least on one dose we can give somehow. In the hospital, somehow staff will give them. But Hahnemann also in Organon tells no compulsion even for taking medicine. It should be given unknowingly. In aphorism, he has mentioned it.
Yes, I think it needs more discussions on that and have to develop certain strategies in order to treat all these cases. And it is time to wind up the session. May I invite Hariharan sir to express a lot of thanks. Yes, sir. Sir, please unmute, sir. You are muted, sir.
Okay,
Yeah.
okay, I unmuted. Dr. Manoj, thank you very much for giving a chance to appreciate Dr. Sreeja, because her class is very appreciable and academic and very intelligent, and we expect next 1 or 2 classes from her with experience, and thank you very much, Dr. Sreeja. Thank you all for who attended the class. Okay, good night.
Thank you, sir.
Well, it's time to wind up session. We will be back again tomorrow at the same time. Till then, goodbye. And it is all Dr. Yahya, our Joint Secretary, to continue the program in Malayalam.